Hi, everybody. Welcome to our next session here. I'm Matt Savis. I'm from the Lean Enterprise Institute, and I'm excited to introduce our speakers here. We have two. First, Carla Bosas. Carla is the Senior System Process Engineer at Houston Methodist Hospital. Since joining in March 2021, she has been instrumental in strategy execution and culture transformation. Carla brings a practical approach to the organization's top level improvement priorities by utilizing Kaizen events, coaching, and A3 problem solving sessions. Carla is passionate about operational excellence and data analytics integration systems. She actively supports healthcare leaders in developing best practices in patient access by establishing standards in EHR scheduling templates, enhancing demand and capacity management, and optimizing resource utilization. Her contributions have notably improved patient access and flow in breast care centers and MRI departments. Before joining Houston Methodist, Carlos was a CI manager at Howmet Aerospace and a quality and supply chain engineer at eVenture GT in the O&G sector. So from aerospace to healthcare. That's pretty interesting. She holds extensive experience designing solutions for complex business problems, leading transformation projects, and implementing continuous improvement initiatives across various industries. And Stephanie is a project manager at Houston Methodist Sugarland Hospital. She joined the organization in 2016 as a physical therapist assistant focusing on the delivery of acute therapy to inpatients. In 2020, she made a career change and transitioned to the performance excellence team, where she began supporting strategy execution and top level improvement priorities in operations. In her current role, her primary focus is the optimization of all imaging modalities. She leads teams through Kaizen events, 5S events, rapid problem solving, A3 sessions, and value stream assessments that focus on delivering quality care, improving patient access, and improving flow. Stephanie has a passion for problem solving and identifying opportunities to better serve the patients and the staff at Houston Methodist Sugarland Hospital. With that, I will hand things over to Stephanie and Carla. Take it away.
Thank you, Matt. Welcome, everybody. Thank you for joining our presentation today on optimizing operations for early breast cancer detection. Long lead times are not only an inconvenience for the patient, but also signal a deeper issue in your operations. At Houston Methodist Sugarland Hospital, our lead times were 75 days for a patient to receive a screening mammogram. Understanding the effect this had on the patient and the business led us to adopt what we call performance excellence. Performance excellence creates a culture of continuous improvement utilizing lean methodology. The journey we will walk you through today will showcase how the team found a problem of low machine utilization and that it was due to the lack of visibility of demand and scheduling templates being built without understanding demand. So after identification of our problem, we created a roadmap which outlined our milestones for success. First, we began by ensuring that there was strategic alignment within our organization. This required us to secure executive sponsorship, identify resources available to support the project, ensure that we had the appropriate training needed to be successful. We also began working with our change management consultant to create a change management plan for key stakeholders and department staff. Next, we moved to our value stream assessment milestone. The VSA helped to identify the current state of all visit types in our breast care center. We also looked at the data that would be used to drive the decisions for our future state opportunities. Once the opportunities were identified, we then moved into our process optimization phase. Here, we took a phased approach to address the opportunities for each visit type. As we finished each phase, we moved into our final phase of sustain and results. We worked with the process owner to set KPIs for the daily management system to monitor success daily, and we also ensured a proper handoff with the process owner.
At the beginning of this project, our staff was asking for additional equipment to reduce our lead time. Our first step in assessing our breast care center operations was to implement overall equipment effectiveness, or OEE. As you may know, OEE is a traditional measure in manufacturing. With my background in engineering and manufacturing operations, I'm very familiar with this tool, and I decided to adapt this tool to our healthcare industry to evaluate how effectively our equipment is being or was being utilized. OEE focuses on the most critical areas of productivity losses, availability, performance, and quality. Here in the chart, you can see that we identified that we had a really low OEE at approximately 39%, which to me was positive because we knew that we had opportunity and we did not have to acquire additional equipment. The biggest contributor to this loss was scheduling inefficiencies, which were created because we had gaps between appointments and blocked or underutilized slots. Essentially, our machines and staff were not being utilized to their full potential. As Stephanie just mentioned, we also identified that we did not have a clear understanding of our patient demand. Our scheduling templates were being created without an accurate data on our patient needs. The lack of visibility resulted in a misalignment between our capacity and our patient demand. In the chart, you can clearly see that we had a gap in between both trends, and that gap represents the mismatch between the capacity and the demand. The gaps directly contributed to our long lead times. And for us, it was really important to notice or to note that our managers really were attempting to reduce these gaps. They did several different actions. They were trying to really improve one service line just to be affecting or delaying another one. To me, it looked kind of like that game of whack-a-mole, where you are trying to hit one just to get another one pop up and delay you. So what I realized is that this back and forth adjustment was really demoralizing for them and frustrating. Our scheduled utilization was really low. We define scheduled utilization as the total hours of appointment schedule divided by the operating hours. This low utilization impacted our appointment availability. Here in the chart, you can see that our appointment availability was significantly lower than our total operating hours. The gap indicated that even though we had the capacity to see more patients, our scheduling practices were not maximizing the use of our available time. We created a really robust implementation plan with all the insights that we got from our value stream assessment. We knew that a 5-day Kaizen event was probably not going to be making meaningful improvements, and we decided to take a holistic approach and very structured to address all these visit types. We organized our plan in 3 phases. Our first phase focused on improving the number of screening mammograms, which was we had our longest lead time on those, which was 75 days. As we continue increasing the volume of these screening mammograms, we also had an increase on diagnostic mammograms. So that led us to our phase 2, which was improving our diagnostic mammograms. And then as we did that and improved the diagnostic mammograms, we had an increase on invasive procedures. And we moved along to our phase 3 to cater for that. Each phase consisted on different targeted interventions, and we focused on 3 key areas. One was the lead time management, the other one was staffing, and then workflow optimization. We concentrated on creating strategic staffing models, ensuring that we were balancing workloads and improving the workflows and processes and schedule optimization through the execution of different events, Kaizen events, just do it's, and pilots. The structured approach gave us a clear path for our continuous improvement to not only transform our operations, but also our culture. During our process optimization, we used several different problem-solving tools. I want to stop here for 1 second, and I want to emphasize that during this value stream assessment that we did, we dedicated significant amount of time to define our problem. Knowing the exact problem we needed to solve was crucial for us to finding effective solutions. On the slide right here, you can see that we needed to solve we use this tool called 5 Whys to identify the root cause of our low equipment utilization. We began asking, why was our equipment utilization low? Then we continue asking why until we identify the root cause. Ultimately, we found out that our cycle times were longer than our appointment times, meaning that it was taking us longer to perform the exams than the allotted appointment times. This happened because to manage our lead times, our leadership had reduced appointment lengths without improving the exam process. And as a result, our technologists were failing to start the exams on time, negatively impacting our patient experience. Our breast center manager wanted to improve this patient experience and wanted to adhere to on-time starts. So she added buffers between each appointment in the scheduling template, which limited the scheduling efficiency. So our solution was twofold. We first wanted to improve the workflows to align with the appointment times, and then redesign our scheduling templates to remove unnecessary blocks and standardize our templates. To operationalize our solution, we began by analyzing our existing scheduling templates. We needed a significant redesign to increase our capacity by over 60 additional appointments daily. Our first step was to map out each machine in time slots and fit every single patient into one time slot. This helped us define our actual operating hours. When we saw this gap between what we were offering and what our patients needed, we really felt extremely overwhelmed. We started having this created this sense of urgency in us as facilitators, and it really helped us develop our why, like what were we working on this project. Our staff was not necessarily bought in yet. They were understandably anxious about the changes. They were very unsure about how could we see more patients with the same amount of equipment and without adding additional technologists. They feared that they would be overworked and burned out, and they really expressed concerns about our organization, that our organization wasn't prioritizing our patients or them in this change. As facilitators, we really have the responsibility to listen to the people that are doing the work. There really must be a mutual understanding and agreement on the value and the direction of the changes. We must translate the complex concepts that we're working with into something that is meaningful to them and relatable. To do this, we used a creative approach with Lego minifigures and Legos. Each figure represented a patient in an appointment slot. We mapped out all of our equipment and then mapped out also our scheduling templates. We explained that each figure could be one of us or our loved ones. If we physically remove someone from the schedule, we would be denying or delaying care. So we proceeded to ask him, like, who should we remove? Is it going to be your mom? Is it going to be you? And this visual approach really helped our staff to see the magnitude of the problem that we were facing. This model helped them to connect the dots and help them and us to be aligned to start executing the changes. It was essential for us that they understood not just what was happening with the changes, but also why was important and what role they were playing in this improvement path. We reviewed staffing levels and roles throughout our operating hours and discovered that we had an uneven distribution of resources. In the graph on the left, you can see that for 6 hours each day, we had more technologists than scheduled machines. which led to frequent technologist idle time and low productivity. Meanwhile, at the beginning of the day and at the end of the day, we had very few scheduled machines and staff. To meet our patient demand, we needed to schedule all of our machines evenly throughout the day and adjust staff distribution accordingly. Although the number of technologies remained the same, we did modify our staff schedules to align with the new operational hours to ensure that each technology was assigned to a machine. Our promise to the staff was to maintain staff productivity at 80%. And to do this, we introduced a new role, the tech assistant. The tech assistant would handle the non-clinical tasks like room preparation and patient escorting. This would allow our technologists to focus on their core responsibilities, enhancing care and reducing burnout. The addition of these tech assists also enabled us to incorporate regular breaks into the new scheduling template, which would allow our technologists to have some time for them throughout the day to rest and recharge. Okay, so finally, to sustain the changes and continue driving excellence, we developed a real-time monitoring demand dashboard within our electronic health record system. With this tool, we wanted to ensure that we were always aligned with our patient needs, so we wouldn't go back to what we used to be at the beginning. The dashboard provided our leadership team with real-time visibility into our patient demand and scheduling, and this also enabled them to make timely and data-driven decisions on staffing, scheduling, and resource allocation.
Okay, so once we move through all three phases of our process optimization milestone, we could begin looking at the overall sustainment and results. So all visit types now have a lead time of less than 8 days. As you can see on the graph, the blue line represents our screening mammograms, and there was a significant drop in lead times around the August 2022 mark when phase 1 was implemented. The pink line for diagnostic mammograms began to see a drop in November 2023, and the green line for bone density shows a similar time frame. When we began working with the staff, patient experience was their top priority. They showed resistance to the changes because they feared it would negatively affect the patient experience. They had a similar fear when infusing the imaging tech assistants because they wanted to be the ones to build that relationship with their patients, not having someone else bringing them to and from the room, and they only having that in the room time. Before the project started, when we had lead times of 75 days, our scores were superior. So even though the patients had to wait, they still felt good about the care they were receiving once they finally got here, and we didn't want to lose that. So through each phase, the team was able to maintain a superior at 91.5%. Here we show our year-over-year volume growth, beginning in 2021, which we used as our baseline year for data. This is when our lead times really began increasing. People in the organization started asking a lot of questions based on patient and physician feedback, like, why is it taking so long to get in? What are we doing about this? Then if you look in 2022, around August, you will see our first jump in growth with the phase 1 implementation. Then looking at 2023, you see more growth around the October-November timeframe with the implementation of phase 2 and 3. Now to where we are today in 2024, we are currently offering a record number of appointments each month. So just to start of our close of our presentation, lessons learned out of everything you're seeing on your screen right now, I think the most important one is deploying a change management plan early on. You're going to be met with a lot of resistance always, no matter what the scope of your project is. There's always going to be a group of people who are ready for change, and there will be a group who are not. So definitely get your change management plan and start communicating to those key stakeholders. And also, when you're communicating, always ask for transparency. I don't know how many times we would sit down in a meeting with our core team who we thought were, just putting it all out there. And we thought we were getting to the finish line of, say, phase one. And they'd be like, oh, but wait, we forgot to tell you this. And it would delay. So just make sure that you have a safe space for everybody to talk and be transparent. And then my favorite, as Carla touched on, our staff automatically right out the gate, and some of our leaders thought, oh, well, they need more equipment or resources. But we quickly found out that that is not always the answer. One important key takeaway to note here is how infusing best practices and creating standard workflows at our breast center can be used for replication at other breast centers within our Houston Methodist family. So to help tie the remaining key takeaways together and close on what we've shared with you today, I want to share with you a story that helps highlight why we were looking to develop a patient-centric experience. The Breast Care Center project was chosen for a system-wide video to showcase quality this year within Houston Methodist. One of our own employees was featured in the video to share the quality of care she received at the Breast Care Center. Listening to her share her personal cancer journey and hearing her express such gratitude to the entire team and the experience they provided her with was incredibly moving. We knew we were doing good by our patients with this project, but it wasn't until seeing her in the video and hearing her side of the story, we felt like, yes, this is our why. This is why we had so much passion. This is why we never stopped, even if it took us a very long time to get through each of the milestones. We wanted to make sure that our patients could receive the care they needed as quickly as possible. And we also wanted to make sure that we had availability for those patients that really had no intentions of needing breast care right now. For the patient that in 2 weeks is doing a self-exam and feeling a lump, we wanted to make sure that we were ready for them too. And that to us is what delivering quality care is about. Taking this holistic approach helped us to achieve our goal, and we were able to open access to 12,908 appointment slots per year. That's huge, and that wasn't what we set on this journey to do, but it's so rewarding to get to this point for our patients. So thank you for your time, and we will open up for any questions you may have for us.
Thank you so much, Stephanie and Carla. That was amazing. So, more patients, shorter lead time. That is in that chart of lead time down to, you said 8 days, and it was high as 60. I think I saw on the chart.
75.
75. That is astonishing, and increasing capacity by a huge amount. That is excellent. If you have questions for Stephanie and Carla, please put them in the Q&A. There's one in there already. This is from Viet Nguyen. And Viet asks, did you run into any form of skepticism from the personnel regarding the implementation of this new MO, namely increasing the volume of patients per day versus maintaining the quality of the act itself? And if so, how did you convince them that the patients would be served as well as before, if not better?
You want to go ahead?
Sure. There was a lot of hesitation about how these were going to be working. One thing that we did, and we did not mention this, we did adjust their cycle times. They had reduced these cycle times at 15 minutes, and they were not meeting, as I mentioned, their appointment. The actual exam was taking longer. So what we did was to adjust our appointment lengths to 20 minutes. And still with those 20 minutes, we were able to offer 12,000 more appointments. So we really work in good faith with them. It wasn't about rushing them or, making them work harder. It was really about working as a team. And we showed them, we did a lot of practices, if you want to. Like we did our walkthroughs, and then we did our training with them, having like a pretend patient, and then going and walking with them every single phase of the process. And I think that really helped them to buy into what we were trying to do.
And we also worked with them to establish like what was a healthy number of patients safely for them to see every day. So I think we settled on like 80% productivity. That was seeing in an 8-hour day 16 patients, I believe. And also infusion of the imaging tech assist, allowing them to get breaks. We actually offer them 2 breaks at 20 minutes when our company policy is 2 at 15 minutes. So that kind of won them over, making sure they had their dedicated lunch. Previously, they were running into lunch. It was not easy, but having them involved in the decisions, I would say, really helped.
Yeah.
Working together to solve the problem. So important. Um, you showed, oh, another question just came in, so I'll save the question I want to ask for a little bit later. How did you engage? Well, here it is. Follow up. How did you engage the entire team to change their mindset?
Well, really kind of what we just hit on, making sure that the team had buy-in in what we were doing, and really the Lego model too. Your frontline staff don't typically know how many patients are waiting to come in. And in our organization, in the imaging department, before the dashboard Carla created was available, they really didn't have any idea either. And we kind of showed them that and then let that sit for a little while with them. And for the most part, they were very engaged with, well, I don't want my mom to wait. I don't want anybody to wait. We actually have a personal story of someone waiting and then having to be like, hey, what about me? I've been waiting 2 weeks. And they were like, oh my gosh, somebody in our organization is waiting. And it was like, well, yeah. And if she's waiting and she works next door every day, what about everybody else in the community? So I think that was really the tipping point, engaging them at all times. And then when we really just laid it all out there and we're transparent, it's like, hey guys, you have how many open referrals did we have that we hadn't closed? Like over 6,000. It was crazy.
It was like 1,600.
1,600.
Yeah, but I also want to highlight too, Steph, the voice pillar.
Oh, yes.
I think that the voice pillar was a way for them. Like we do have a daily management board. We have foundational tools implemented. And I think the voice pillar, they would really express how they were feeling, the things that they were seeing. We follow up on those. So it was important for us to go and do Gemba and then listen to what their concerns were. We involve our physicians too, which I think that was very critical. Our chief physician, our radiologist, he was really engaged into this too. Having him bought in also supported what we were trying to do. We had to involve everybody, even the front desk. So we had to work with the front desk. We had to work with the registration people. Everybody every day. Everybody had a part to play. We did Kaizen events throughout, the entire 2 years affair that we had. We did Kaizen events. We also involved our executives so they could also go and talk to our staff and listen to their concerns. We never closed the door. We never stopped listening to what they had to say. Sometimes we obviously could not go in the same direction, but at least gave them that opportunity to express some of their thoughts and concerns and try to work with them as much as we could to redesign to meet what they were looking for.
We just have a little less than a minute left, and I'm very curious about the Lego model there. Do you think that made a difference versus just numbers and charts because they were people? They were little Lego people. Do you think that had an impact on people?
Absolutely. And I feel like that's now become a staple in all of our projects moving forward is the Lego activity just for the visualization. And we were very transparent with them, like Carla shared in the presentation, when they were like, oh, we really need a break here for a team meeting. Okay, well, how many people is that? It's an hour meeting. Okay, well, let's pull 3 people out. These are 3 people. Is that your mom? Is that your sister? Is that you?
Yeah.
Who is it?
Yeah.
Wow. So that really made a difference.
Yeah. And our radiologist actually was kind of funny because we were like, is this your wife, Dr. Boatman? Like, do we need to remove your wife from the schedule? And I think that really, we have a very close relationship too with our breast surgeons. And we used to have a lot of problems with them finding availability for their patients, which is really critical because they have to follow their journey, their treatment journey. And now we used to do allocation to blocks that were allocated specifically for them. We removed that, and yet, we were able to connect the dots and saying all of these patients are the same. They are worth the same for us. They don't have a face. They are not Dr. Such and such surgeon patient. These are people, and this could be your mom. This could be you. That actually helped them to connect the dots. We really do believe that.
Wonderful. Saving lives. That was a fantastic story. Stephanie and Carla, thank you so much for taking time to share that with us, and thanks to everybody for joining. We'll wrap it here.
Awesome. Thank you, guys.
All right. Thank you.